Thanks for being here.
Great. Yeah, thanks for having me.
I want to introduce Dr. Eric Forman, Medical and Laboratory Director at Columbia University Fertility Center. He's a nationally recognized expert in IVF, embryo selection, and fertility preservation, and we are incredibly lucky to have him today. After the 30-minute Q&A, we'll stop the recording and move into the emotional support portion of the group. So that's where we'll shift into peer connection, and I'll invite you to have your cameras on and to contribute if you feel comfortable. Okay, let's get started. Dr. Forman, you ready?
Yeah, I'm excited to talk and hear your question. Just want to again introduce myself. I'm Dr. Eric Forman. I'm the Medical Laboratory Director at Columbia University Fertility Center here in New York City. And I've been in this field for more than 12 years after training with an interest, especially in IVF, the lab, pre-implantation genetic testing.
Let's get started. Before starting IVF, is it better to do a deep dive to identify any potential underlying issues that could impact protocol, or is it usually best to begin with a standard approach and adjust as needed?
Okay. So, I think it's always good to do a thorough evaluation. Balancing time with moving forward, but I think it's pretty standard to assess ovarian reserve and get a sense of what we might expect. And that influences our choice of protocol and dose. But the workup can be done pretty efficiently. So it shouldn't really delay one by a significant amount of time. So I think it should be individualized, but can be adjusted along the way if one winds up needing multiple cycles.
Okay. Thank you. Number 2, is there hope for someone 44 years old with their own eggs, even after failed rounds of IVF and IUI?
Okay, that's a tough question. So we know age has a big role in fertility, especially female fertility. We still think that women are born with their eggs, gradually use them, so quantity declines, but many women are still ovulating and having regular cycles even at age 44 plus. So there's also a quality factor, and quality is hard to measure. One way of measuring it is genetic quality or ability of genetics, ability of eggs to be normal. And there's a lot of data now as pre-implantation genetic testing has been around for a while that as one gets to the age 44, we think 90% plus of eggs and embryos are abnormal, but it's not 100%. So I would never say never. Sometimes I hear patients that say a doctor or someone told them they would never get pregnant, and then they do. And again, I don't know if they really said never or that was how it was interpreted. But yes, I think there's still hope. Again, with that limited information, it is still possible, but it can be very difficult. And if many other types of treatments have been tried, it's also reasonable to definitely think about things like egg donation, embryo donation, adoption at that point.
And actually, the next question has to do with that. How do I know I'm ready to move forward with donor eggs?
I was actually listening to one of your prior shows. So Dr. Amy talked about being excited about it, which was, I think, a nice perspective. That is a different perspective from me, but I similarly think you have to be ready for it. You have to feel comfortable moving forward and not having regrets. And that is an individualized decision between a patient, a couple, and their doctor. For some, it may not require doing any prior fertility treatment. Like there's no absolute requirement that you have to have done IUI or IVF or had an embryo transfer or anything. But I do sometimes see patients that I think feel that way. But again, as you get to a point, like we talked about with the prior question, beyond a certain age, success rates get low. Again, not zero, but there comes a point where if one can only do a limited amount of treatment for whatever reason, emotional reserve, where disappointment is so challenging, financial resources, time, egg donation has a significantly higher chance of success. It's almost always the highest chance, but it's a decision at what point is that the best option. I think for most patients or couples that have tried other treatments, again, it gets to a point where they feel comfortable that they gave it their best effort. The chance of it working if they continue treatment is, again, maybe not zero, but extremely low. And going through more disappointment, more expense is going to only delay and make it maybe more difficult to be able to do something that really often has a very high chance of success. And our perspective shifts from hoping we get really lucky and beat the odds to really expecting to have success and hopefully on the first try. Also, it depends if some couples want more than one child, if that's really important. Again, as that patient asked earlier about age 44, it's still possible, but we're really like hoping to beat the odds, but it's even more likely to do that 2 or 3 times, where with egg donation, that's can be expected if everything else is healthy, uterus is normal, and you get through a healthy pregnancy, you could have 2 or 3 children, even starting at 44. So it's a lot to consider with, again, mental health specialists helping us and doctors and nurses, but I don't think there's a clear answer that works for everyone. That's some of my thoughts.
And I think that's a great answer because I think you're right. There is the physical part and the medical part, and then there's also the mental part. How much more can somebody withstand? Next question. Do you ever recommend low-dose IVF for women with low AMH or diminished ovarian reserve, especially in the cases of advanced maternal age?
Yeah, we do use low dose protocols. I think there's good evidence to support the thinking, classically has been that the more medication and the more gonadotropins like FSH you give, the more follicle growth, but that only works to a point and isn't always true for everybody. We're learning more and more. There's some uses of AI analyzing large data sets of patients going through stimulation, and it's not always the case that like more medication or longer stimulation gets more eggs. At some point, there may be diminishing returns. So one, even for like normal responders, I think we could do better about targeting the right dose and not overstimulating. Then we get the patients with very diminished ovarian reserve, low follicle count, low AMH. Sometimes even if you gave the highest doses, you're going to expect a relatively low response. So it's not cost effective, especially if one is paying for all this on their own. So that's a factor, which the medication are the biggest cost, but they contribute over time. So if you could save thousands of dollars, it could make it easier to keep trying. But even if it's covered and medications are not a cost factor, there are some patients that seem to do just as well or better with less medication. So I think it's another option to try. We often start with high dose protocols, but if one doesn't respond well to that, sometimes even with, again, the highest dose protocol, we see no follicle growth, canceled cycles, even in someone who typically ovulates regularly or might have 2 or 3 follicles growing, even with just Clomid pills if they were trying IUI before. So a hybrid of Clomid and a lowish dose of injections often is adequate to get multiple follicles to grow. And I don't consider that mini IVF. So we're not trying intentionally to get CU eggs. Like we're hoping that someone responds well. It's just some women seem to respond just as well or better without maximum dosing.
Is there any evidence that a natural cycle transfer leads to a better outcome than a programmed one?
It's a good question. Again, there's more and more research and discussion in our field about natural cycle frozen or modified natural cycle frozen embryo transfers as opposed to medicated. And I could say, I think it's debatable if there's evidence that it's better, but I'm not aware of any evidence that it's worse, like at least as good. There's not a huge, but there's a randomized trial from Italy that compared natural cycle frozen embryo transfer to programmed or medicated and was similar success rates. I believe there's a study from China using modified natural cycle with letrozole in women with PCOS that maybe even did slightly better. There's some retrospective studies where clinics look at their experience and some have found what looks like higher success even with natural, although again, that could be biased by different factors as to why was the natural cycle chosen, but nothing that I'm aware of that says it's worse. And then you get to some evidence that there may be health benefits to natural cycle frozen embryo transfers. And this is also controversial, supportive of programmed cycles. They work well. We have a lot of experience and data. The timing is very standardized. Sometimes it just, again, some people travel a lot or have jobs that don't allow for natural cycle or it's not as predictable. So I'm definitely not anti-programmed cycles. and the outcomes are safe and the vast majority of the babies are healthy. But there have been some studies suggesting that there might be a higher risk of hypertension in pregnancy, maybe preeclampsia in pregnancy that started out without what's called the corpus luteum, which is the follicle left behind after ovulation. So fresh transfers, which we don't do that much anymore, there's multiple of these corpus luteum cysts. In a natural or modified natural cycle, a woman ovulates. And the idea there is that the corpus luteum or the ovary doesn't just make estrogen or estradiol and progesterone. Those are two essential hormones. And we've learned amazingly that we can prepare a uterus and get very good results with just giving those two medications. But other factors are made that may have a role in some patients in implantation and risk of things like preeclampsia later. But the differences are not huge. Most of our data on obstetrical complications, preeclampsia, is not from IVF, it's from natural pregnancy. So it's not like this guarantees that someone wouldn't get hypertension or preeclampsia. In the studies that have been out there, it's been mostly differences in like mild preeclampsia, which happens near due date, third trimester, and resolves usually with delivery. So still an open question if it's safer or better, but I think it's at least as good, and for some women, maybe better and maybe easier on them.
Thank you for that. Okay, next question. It's a little bit of a longer one because it's clumped, but when someone has both endometriosis and adenomyosis, do you typically recommend Lupron suppression alone for 2 to 3 months or laparoscopy followed by Lupron? And then also, would laparoscopic surgery help improve egg quality in someone with silent endometriosis and adenomyosis?
All right, so it's a big topic, I think, about endometriosis and adenomyosis. And there are like a lot of things in our field, there are different perspectives on it. Endometriosis is fairly common. A lot of our patients who wind up going through IVF have endometriosis and we don't even know it. There's a well-designed study one of our doctors in our group, Lauren Bishop, did years ago that looked at women that they really knew they had endometriosis, they had prior surgeries, and women who very likely did not have endometriosis because they had a good other reason to be doing IVF. Like you could have multiple things going on, but they had, I think, severe male factor, or were doing PGTM, which is genetic testing for a specific reason. So no reason to think that they had endometriosis. And these patients all were doing IVF, PGTA, made normal embryos, went right into a frozen embryo transfer, and did equally well. So that suggests that you don't necessarily have to suppress or treat everyone with endometriosis. And those are patients with a known endometriosis proven by surgery maybe years before. So that's one debate in our field, that there are some who suppress with months of Lupron anyone that they suspect endometriosis, even the first transfer. I'm not convinced that's necessary. I'm not saying that's bad, but I do have concerns because that has side effects. And one side effect, in addition to side effects of low estrogen, like hot flashes, mood changes, one side effect is also time. Time is important, especially as we get into more advanced reproductive ages. So if you spend 2 or 3 months with Lupron suppression and then transfer doesn't work, which may be more related to the embryo itself anyway, we maybe lost important time where we could have been making more embryos. Say, surgery also takes time to schedule, to recover. It's very safe if you go to a skilled laparoscopy surgeon, but there's risks to anything. And if you do enough surgeries, someone is going to have a complication that might delay pregnancy attempts. So that's for the endometriosis part. Adenomyosis is definitely more complicated. The diagnosis is not as standardized, ultrasound, MRI findings. But if someone has significant adenomyosis, I think there's more and more good evidence that can affect the chance of implantation and risk of miscarriage, even with normal embryos. The evidence for suppression or surgery, I think, is less strong, but more than with endometriosis. So in that situation, often we will suppress with Lupron, either with a daily Lupron for weeks, or if it's really significant, 2 or 3 months of depot Lupron. But I wish we had better, well-designed, randomized trials proving that really was significantly better and it was worth spending that time taking side effects.
There's another question similar to that, which is for someone who has PCOS and endometriosis and adenomyosis and has 6 euploid embryos, but only 2 were given over 50% live birth potential. Would you consider a gestational carrier?
I mean, for those reasons alone, again, this is like before the decision with egg donation. That's a big shift. Most of our patients want to carry and experience pregnancy and deliver. Using a gestational carrier or surrogate is very different from that. Sometimes it's the only option or the safest option. So it's an amazing option. But if someone doesn't have an absolute reason, like a severe medical reason or really severe uterine reason to not try a transfer, I would not typically recommend that upfront. And again, depending on the situation, someone with PCOS usually has a good egg supply, making 6 normal embryos. Again, I don't know why the other ones are quoted less than that. Maybe they're from day 7, which some studies suggest have lower chance of success, but still someone made 6 normal embryos. Maybe they're not able financially to do another IVF cycle, but another IVF cycle is a fraction of the cost of gestational carrier. So I would typically do your best to make sure the uterus is as normal inside and try at least probably 2 or 3 transfers, honestly. And then if that's not working and it's really thought to be a uterine factor, maybe make more embryos while you think about carrier. But I would rarely do that upfront without trying.
Okay. And then there's a question that overlaps here, so I'm going to ask them both. One person said, I've had 4 natural miscarriages, 2 euploid failed transfers, and 1 euploid miscarriage. What would you test before trying to transfer another euploid? And then the other overlapping one is, what is your approach for patients suffering from recurrent implantation failure?
Yeah, that's 2 big topics again. So recurrent implantation failure first, it's very controversial. Like, what is it? There's some who question if it's even a thing, like a true diagnosis, or that it's over diagnosis or overuse, right? So the last patient said only 2 of her embryos had a 50% chance. Studies vary, but normal blastocysts maybe have a 60%, 65% chance, maybe at best, but it's not 100%. And then if they're not tested, you don't know if they're normal. It's less than that. If they're day 3, so less than that. There used to be definitions like failing 2 or 3 transfers, but it really depends. Are those untested embryos from an age where there's a high chance they weren't normal anyway, and then not really implantation failure, then the embryo just wasn't capable? So there are some newer definitions that some groups got together, like ESHRI, the European group, and then an international group, and have landed on, and again, I think there's different opinions, but 2 or 3 euploid, high quality blastocysts. At least that's a time where it's maybe reasonable to do more investigation, because if everything looks good and you transfer 1 normal embryo and a third or up to half the time these embryos don't work, that doesn't mean that there's anything wrong, that there's implantation failure. So I would try not to overreact and do unproven things or change just for the sake of change. Even if 2 or 3 normal embryos don't take, that even that doesn't mean that there's something wrong. And there's some studies showing like the 3rd or 4th transfer has a similar success. And if there really was a significant proportion of the population that had some real implantation barrier, then after 2 or 3 transfers didn't work, we should see a major drop off in the chance of success of the third or fourth try. And we don't see as big of a drop off as you would suggest. So one, I think, again, recurrent implantation failure is probably rarer than most patients think. And it's often just a matter of continuing to try if hopefully there's enough embryos to keep trying. I think the best you could do is do your best to make good quality embryos, have a good number of them, make sure that there's not anything obviously abnormal in the uterus with a good evaluation of the uterine cavity, and then do a well-timed frozen embryo transfer and keep trying. If that's continuing to not work, or the patient that has euploid miscarriages, then there's additional tests that some do earlier than others. There's a condition called antiphospholipid antibody syndrome, which there's a panel of antibodies that can be tested. It's relatively rare, but if found, then there's an intervention that can be given, baby aspirin and anticoagulation with heparin or Lovenox, that has been shown to lower the risk of miscarriage. Also, though, those women are at higher risk of complications in pregnancy, like blood clots, DVT, PE, placental abnormalities, severe preeclampsia. So I think that patient should have more of an evaluation that's had these normal embryos that keep miscarrying. And again, I want to look at the quality of those embryos, the protocol, the frozen embryo transfer. Was it medicated or natural cycle? And again, that's kind of where I go. Additional testing for endometriosis is often done at that point. I think I'll stop there. There's a big topic.
What are your thoughts on PRP, and why doesn't Columbia offer it?
So PRP. So again, I think anything that comes up, there should ideally be evidence to support it. Just because there's something new, a new test that sounds good, doesn't mean it's better. Like, we don't know that it isn't worse or just doesn't change anything. And again, it takes time. Certain things take time, money, resources that are limited and could detract from the ultimate goal. So PRP is used in other areas of medicine. It has been used or looked at for different purposes in reproductive medicine. Some use PRP intra-ovarian, like injecting it into the ovaries. And I don't think there's great or real valid data to support that improves outcomes of subsequent IVF. There have been some studies that have looked at patients with very low ovarian reserve or primary ovarian insufficiency. And again, I don't think evidence supports that the outcomes are better after. And again, there's cost, and it's somewhat invasive to inject something into the ovary. So it's not without any risk or cost. PRP can also be used in the uterus. There are some small but randomized trials that have looked at it for women with recurrent implantation failure, which I mentioned earlier, maybe is controversial. Did all these patients in these studies really have something abnormal, or was it just embryos? But at least there's some evidence pointing towards possible benefit. And so we have offered in that setting PRP a couple of days before a transfer. I think we need ideally better, larger studies and trials. And then there's PRP for persistent thin lining. And a lot of things over the years have been tried for thin linings, like Neupogen infusions, Viagra, acupuncture, the things that are safe, but again, have costs and just have not been proven across the board to improve outcomes. But PRP is being tried. I think there are some trials going on, and it's something that we've, again, looked at, but don't have compelling data that it's definitely improving outcomes for those patients.
Dr. Forman, I want to respect your time. And also, there's a lot of questions. People will probably be upset if I don't ask.
I have a few minutes, but
Okay.
right after that.
Okay. After my egg retrieval, I was told that the doctor could not access my right ovary. Is that common and could it be predicted?
I wouldn't say it's common, but it happens. I think we do monitoring throughout a stimulation. So some patients will know that it's always difficult to see a particular ovary, and certain tricks, manipulating the probe or pressure abdominally. Sometimes it's unexpected, but usually there's an idea and often some risk factor like fibroids maybe displacing the ovary, making it more difficult to reach, or prior surgeries, endometriosis. So I think there could be some idea that it might be a difficult retrieval, but maybe for some reason it got into a location that was just difficult to access. So I can't necessarily comment on this unique case, but there are things that are typically done at that point under sedation, like an abdominal pressure to try to bring the ovary down. If it's high and difficult to reach, abdominal or transabdominal retrieval can be done safely if, again, the ovary is more accessible that way. But in safety, obviously, is the most important thing. We don't want to be placing a needle where it might be puncturing other organs or cause bleeding or infection. So again, I think it's possible that doctor just felt like it couldn't be safely accessed.
I've had multiple autoimmune conditions, including rheumatoid arthritis. After 2 miscarriages and 5 failed IVF cycles with no euploid embryos, I'm now planning to use donor eggs. Would you add any additional tests before transferring?
The first part again?
She has multiple autoimmune conditions, including rheumatoid arthritis.
Yeah, again, I think making sure that those conditions are under control, that you've seen maternal fetal medicine, preconception, like once you're pregnant, that's just the beginning. Then there's a long journey of getting to healthy, hopefully near due date for a safe, healthy delivery. So I think we focus so much on getting viable embryos, getting implantation, but then there's a whole rest of the pregnancy. So I think if the condition is optimized and under control, that story of the embryo not implanting, we heard earlier just about the success of normal embryos. That doesn't necessarily mean there's an immune reason for that. And we'd have to get more information about the quality of embryos. But I think if everything looked again normal with uterus, with overall health, I don't think necessarily there's evidence to add other things or do other tests. But again, that's my approach.
I have mild Hashimoto's, but I'm euthyroid. Does a gluten-free diet actually help in cases like this? And then I'm going to tack on to that. Does a gluten-free diet or any specific diet help in any way, in your opinion?
Yeah. So Hashimoto's is a different autoimmune condition. Euthyroid means that the thyroid actually is functioning normally. Like it's a risk factor for developing hypothyroidism or postpartum thyroiditis, like inflammation of the thyroid, hyper or hypothyroid. But it sounds like this patient, again, her thyroid is functioning normally. It's controversial whether that affects reproduction. Some small studies suggested maybe a higher risk of miscarriage, maybe a benefit to low dose thyroid supplementation, but other studies have not really conclusively supported that. And there's been a move away from over treating thyroid when it's functioning in the normal range. I'm not a medical endocrinologist. I'm not a dietitian. I'm not aware of any evidence that an empiric gluten-free diet in someone who doesn't have celiac disease, but has Hashimoto's or anti-thyroid antibodies. I'm not aware of any benefit of that. And across the board, again, there are clinicians who make recommendations on diet. I don't think there's good evidence that going on a gluten-free diet gets you more eggs or better eggs or more normal embryos or makes your normal embryos more likely to implant. So if you want to try it and you like it or feel better, there are some people who claim to feel better on a gluten-free diet. I think that's reasonable, but I wouldn't medically prescribe it or recommend it unless someone has evidence of celiac where that it can be related to chronic inflammation and risk later just overall health. And there's some evidence for increased risk of miscarriage in untreated celiac. So if you're on celiac, yes. Otherwise, it's a personal decision in my view.
Okay, thank you. I'm going to ask you two really lighthearted questions and then let you go. If you had to swap careers for a month and you were already amazing at it, what would you choose?
Sometimes I think about being like an Uber or taxi driver, like just driving around or picking up people and hearing like where they're going, what they're doing. And so I might
That's a great answer.
That's not as intense as what I do.
Not getting these questions.
Mhm.
Okay.
Mhm.
And then second question, do you go to bed with your email inbox at 0?
Not like in terms of new messages. Usually I would say, not always though. But I do like to try to like check and see what's there. And then sometimes if it's just late and I'm tired, I'll not necessarily respond to everything. But the next day before seeing patients I try to get all the questions answered.
Okay. Thank
Good
you so
question.
much, Dr. Forman.
Guide patients and get them through this journey. I think that's the most difficult part. Like I said, a lot of it is just continuing to try to never take that next step. It may not work. And sometimes it's just a matter of keep continuing to try. We didn't get to protocols. I know there were questions about it, but there's not evidence that one protocol is better than another. But sometimes you just land on something for a particular patient and we don't have a way to predict that, or you just get lucky and you have that better group of follicles and eggs. And if you don't try, you might never get that lucky cycle. So I know it's hard, obviously emotionally, physically, financially, but if there's still, again, a good chance and you're up for it, I would encourage people to keep trying and use support like you to help them get through it mentally, spiritually. All right. Have a good evening. It was really nice to talk to you.
Thank you, Dr. Forman.
Thanks
Thank
for the
you
great
so much.
questions. All right. Bye.
Bye.